Good evening, and thank you very much to Therma Fisher for inviting me to speak at this webinar. My name is Lina Heiser-Garvey. I'm a professor at Copenhagen University and a consultant at the Allergy Clinic Gentofte Hospital in Denmark. I'm going to talk to you today about investigations in drug allergy. Now, drug allergy or drug hypersensitivity, which is really the overall term, is only about 5 to 10% of adverse drug reactions. The commonest causes of adverse drug reactions and drug hypersensitivity are antibiotics, NSAID, local anesthetics, general anesthetics, and others, and I'll come back to that. The problem with drug hypersensitivity is that the lack of knowledge induces fear in both patients and healthcare workers. So drug allergy can actually lead to a number of for bad consequences for patients, such as delays or cancellations of treatment, suboptimal alternative treatments, even avoidance of necessary treatments. And on the patient side, actually avoiding taking any medications because they're worried about the allergic reaction. Now, a lot of patients don't know the difference between allergy and non-allergic adverse effects or side effects, which are obviously much more common. So nausea, vomiting, diarrhea, all those sort of side effects are well known by all of us healthcare personnel. They're usually dose related and will, in some cases, diminish on continued treatment. And of course, the need for the medication will have to outweigh the adverse effect. So everybody will accept to have some nausea and vomiting with penicillin if it will actually cure their pneumonia. So non-allergic adverse effect can be life-threatening, but that is rare. But a lot of patients will actually find some of these adverse effects unacceptable. Now, drug allergy can sort of roughly and crudely be divided into two: the non-immediate reactions, which are more common. And what we, of course, are very worried about are the TEN and the Stevens-Johnson. And in fact, it's a very small proportion. What we really see are the maculopapular exanthemas. The onset of the delayed reactions are sort of hours to days after the exposure, whereas the immediate type reactions, as shown here, about 20% of the patients with drug allergy have much faster onset, minutes to hours after exposure. And again, what we worry about is anaphylaxis and swellings of the throat and mouth. But what we really see is also skin symptoms. The mechanisms are many and varied. This is a mast cell, and up here we've got the IgE antibodies and the allergens, sort of showing the IgE-mediated mechanism. There are other ways. Certain drug groups are said to activate the MRGPRX2 receptor directly. This would be quinolone antibiotics and muscle relaxants during anesthesia. There are some drugs, such as opioids and radiocontrast media, that might actually activate the mast cell directly. And then, of course, related to vaccines, we've been hearing about complement activation and pseudoallergic reactions related to that, but we'll come back to that. Now, how can you diagnose an immediate reaction? Well, if it's an IgE-mediated reaction, as you can see here, to chlorhexidine with preformed antibodies, you get degranulation when you get exposed to chlorhexidine, and you get an increase in tryptase. As you can see here from the time zero, at about 60 minutes, tryptase will peak, whereas histamine peaks a lot earlier and is quite difficult to sample. Now, before, people said that tryptase had to be over 11 to be elevated, but now we know that you have to compare with the patient's own baseline, and in fact, quite discrete changes in tryptase from the baseline can be relevant. So if the reaction in tryptase is greater than a baseline times 1.2 plus 2, you could actually have a clinically significant IgE-mediated allergic reaction. Tryptase has to be taken, as you can see from the dynamics here, ideally between half an hour and 2 hours after the reaction, and the baseline has to be at least 24 hours later, so you're sure that the tryptase is normalized. So investigations in drug allergy, like in other types of allergy, a very detailed history is always key. In vitro tests, we can use specific IgEs for penicillins and for a few other drugs. Otherwise, the basal activation test is sometimes useful. And then skin testing with skin prick test and intradermal test, which can be used for immediate type. For delayed type, you can use delayed intradermal test with delayed reading or patch testing. So just for because actually there's a lot of variance in how people do the intradermal test. This is a study we did a little while back in the ENDA, the European Network for Drug Allergy, and we published how we think you should do an intradermal test. And key is really to use the fixed volume, because you will reduce risk of severe reactions on intradermal. And also we showed that you can do them on the arm or the back. Really, it doesn't affect the test itself. Drug provocation is one of the tests that we use a lot in Denmark, where I'm from. Drug provocation is good because it will reproduce what actually happened to the patient. Skin tests and in vitro tests have got sensitivity issues and sometimes also specificity issues. But here with the drug provocation test, you can adapt it to the risk. You can confirm and rule out allergy, and you can find a safe alternative. And this is from a study that we did in our department a little while back. Basically, we looked at all the drug provocations we'd done with a number of drugs. You can see here 1,913 referrals we had in the period we were examining. And everything that's blue is penicillins. And all the way to the orange here, you have antibiotics. And then you've got a few other groups and local anesthetics and other drugs. And these are the patients referred on the suspicion of a drug allergy. And this is actually after we tested them. So only 11% tested positive. As you can see, again, penicillins dominating, and some of the other antibiotics, which in Denmark are macrolides and metronidazole, among others. Local anesthetics, no reactions on actual provocation, and I'll show you some data on that later. So basically what we did, we looked at a 5-year period, 1,913 drug provocations. We'd done specific IgE for penicillin. So if any of those were positive, we would call them allergic on the blood test itself. But when we did the provocations on all the IgE negative patients, 11% tested positive. And of those, only a fifth were actually immediate type reactions. The remainder were delayed type. Often amoxicillin, maculopapular rashes to amoxicillin, and only one out of the 211, or even one out of the 1,900, had anaphylaxis during provocation, which was obviously managed easily in our department. So if we look at drug allergy in our clinic in Gentofte, basically referrals have increased massively over the recent years. About 60% of all referrals we get now are drug allergy referrals. 90% of them are antibiotics, 80% penicillins, as we still use a lot of penicillin in Denmark, and only 2 to 3% are actually reporting anaphylaxis. Most are referred with some sort of rash. And in addition to that, we know that 10% of hospital inpatients report a penicillin allergy, and that 80 to 90% of those can have the allergy disproved on investigation. This means that penicillin allergy is something we really need to look into. And one of the main reasons, obviously, penicillins are certainly in Denmark for some infections better than the alternatives. But there is antimicrobial resistance, which is quite a problem. And this is old figures. So this is actually from 2004, used in an OECD report in 2015. And basically what it shows is total antibiotics up this axis and resistant pneumococci up this axis. And so you really want to be here. Denmark has a low antibiotic use and low resistance, but you can see several countries in Europe are much higher up this graph, showing a lot of antimicrobial resistance. And in fact, the World Health Organization has stated that antimicrobial resistance is one of the top global public health and development threats, and that millions of people die directly from resistance, or from death, dying from where the antimicrobial resistance has contributed to their death. So there's an international focus on penicillin allergy and delabeling, because this figure of 10% of patients is quite universal, and the fact that 9 out of 10 can have the allergy disproved is also quite universal. So basically, we have to think smarter. We have to look at the risk that these patients' stories they actually give. And what you have to do is get the story and then tailor the investigations to the level of risk. So the higher the risk, the more investigations, the less risk, the less investigations are needed. And we really have to address this to address the scale of the problem of penicillin allergy. But it's a challenge to create a risk stratification algorithm that can work for different levels of risk and in different settings. So this one size that doesn't really fit all is probably the way we have to think about it. And this is just some of the many publications on risk stratification and different approaches on how to act investigate low risk patients. We've also addressed this in the EAACI, so the European Academy of Allergy and Clinical Immunology. We did a paper on drug provocation testing, and here we've put in this risk assessment, which is mainly for penicillins, but can be used for other drugs as well. And so if we start in the green, on the green side, these are patients who haven't actually got allergy, who just have vomiting or diarrhea or non-allergic side effects. Those patients, you should be able to remove the label after talking to the patient and tell them there's no investigations needed. As we move further this way, we see higher and higher risk. We have some mild MPEs, mild maculopapular rashes. Those should be able to actually be delabeled with direct provocation. There are some other situations where we suggest that you maybe do some skin testing or a two-step provocation. And then we get to the high-risk patients, so anaphylaxis patients and the very severe delayed reactions, the scars. For anaphylaxis, really, you don't want to, for both of them, you don't really want to give the patient this reaction again. So you want to do all the tests you can to try and avoid it, and you don't want to do skin testing that risks putting the patient at risk either. So if you could actually diagnose these patients on a blood test, that would be really helpful. And this is reflected in the YACI guidelines for hypersensitivity to beta-lactam, so penicillins and other beta-lactam antibiotics. And you can see here high up in the algorithm, the specific IgE test is suggested for patients with severe anaphylaxis. You do a blood test before you do any skin test or any other investigations. And we've had a look at this in Denmark. We did a lot of specific IgEs in patients, and basically we wanted to see if we could show whether it was actually giving the patients whether we could sort of detect an increased risk of anaphylaxis in patients with elevated specific IgE. So we looked at 430 patients who had a positive specific IgE from our lab database, and then we compared it with the provocation database where patients had lower specific IgE, so not elevated specific IgE, and we compared it using multiple logistic regression to see if we could see any predictors of a positive specific IgE. And interestingly, very strong predictors were immediate type reaction and treatment with adrenaline, also circulatory symptoms and any treatment and angioedema. And males of over 65 were predictors, but the strongest predictors were immediate type reaction and by treatment with adrenaline, indicating that patients who have had these type of reactions, if you do a specific IgE and it's positive, you're quite likely to be able to stop there and tell them that they're allergic. So that was penicillin, some of the most common allergies that we have. Non-steroidal anti-inflammatory drugs, also very common. I'm not going to say a lot about them other than the fact that there's a lot of geographical and variation in the incidence and specific drugs that are causing allergic reactions. And there are lots of different mechanisms, most of them not IgE mediated, and therefore skin testing isn't actually that helpful. There are types of NSAID intolerance that are associated with aspirin intolerance, eosinophilia and asthma. NSAIDs can cause exacerbations of existing chronic urticaria, which can be quite confusing. And there can be these multiple reactions to several NSAIDs in some patients. And NSAIDs can even be a cofactor in anaphylaxis. But in a lot of the patients with the aspirin intolerance and the several NSAID reactions, you can use the selective COX-2 inhibitors. And this is what we often end up doing in our clinic. And lastly, there are actually IgE-mediated reaction. Rarely in Denmark, we see them to ibuprofen, which is the NSAID that is most commonly used in Denmark. but quite a common cause of hypersensitivity reactions, but not a lot of them IgE mediated. Then I'll move on to perioperative hypersensitivity, and these really are the most complicated patients in drug allergy investigation. And what you need is anesthesiologists who knows what's been going on in the operating room, to liaise and work with allergologists who know all about allergy testing. And really, you need to see a critical number of patients to gain and maintain the experience. And really, in the Danish Anesthesiology Centre, which I'm heading, we've been doing this for 25 years. And I'm an anesthesiologist and an allergist. And we have other anaesthetists also actually working in the allergy clinic. If you want to know more about the investigations, I suggest that you read this paper, which is the EAACI position paper on the investigation. And really, I'm just going to give you a quick case of a patient who was referred to us after a reaction during urotoscopic stone removal. Basically, they gave the anesthetic, no problem. Then they gave IV tobramycin, and suddenly he had all the symptoms of anaphylaxis, stabilized on adrenaline fluids 10 to 15 minutes. And the surgeon was asked to hurry up the operation. When he wakes up, he then asked again, have you ever had an allergic reaction? Says, oh, yes, I did have a rash at the end of surgery last year. But basically, they decide this happened at the time of tobramycin administration, so probably this was due to tobramycin. This was the picture of his rash that he had the year before, but tobramycin hadn't actually been given at that surgery. So he didn't have any hay fever or reactions to drugs, no itch or rash. Oh, he had an itch and a rash, though, after blood sampling, which gives a bit of a clue. And then he had this urticarial reaction here where tobramycin wasn't administered. And when we investigated him, the tryptase was markedly elevated, as you can see, 26 and a baseline of 4. And we did specific IgE antibodies for ethylene oxide and latex and chlorhexidine. And the chlorhexidine antibodies were very, very high. And skin testing could confirm this allergy to chlorhexidine, and everything else that he'd been exposed to were tested and tested negative, including tobramycin. And this is just to illustrate that when you have a setting like the perioperative setting where you have multiple allergens, you really need to test them all because you can't guess which one is the culprit. For investigating chlorhexidine allergy, basically it's used widely in the healthcare sector. And so in our clinic, we test all patients who have had a reaction somewhere in the health sector, we test them with chlorhexidine. Sometimes they've had mild reactions that will increase your suspicion, but we tested, as I said, in all patients who've had surgery or reactions in the hospital or a doctor's setting. When we test, we use skin test and specific IgE, and actually the sensitivity and specificity for the combination of skin test and specific IgE is very high. It's over 95% for both. And basically, the specific IgE can be measured at the time of reaction. So if you had a patient who'd had a tryptase sample taken, you could actually measure the specific IgE. And here's an example of somebody who has elevated IgE at the time of surgery. It then increases after surgery, but then decreases again. And as you can see here on further exposure, it increases again, but then it actually drops below the 0.35. So you have to make sure that you don't call a patient not allergic to chlorhexidine on a blood test, because it can be not elevated even in patients with allergy if a certain time has elapsed. This is just our results from the Danish Anesthesia Allergy Centre. This is all the patients we've tested in the period 4 to 21. 749 patients, just under half had tested positive. And you can see here chlorhexidine is a very important allergen in our clinic, in the perioperative clinic, as is antibiotics. And obviously these antibiotics are used in every single patient. So it's not so strange that they are also a common cause. And this is what you also see internationally. I had a PhD student who looked into patients with chlorhexidine allergy. And as I said, it's quite a proportion of the patients we test in the perioperative setting. It's actually 9.6% of the patients that we have in the perioperative clinic that test positive to chlorhexidine, but we do test every single patient. But what is more worrying is that patients will be re-exposed if they're not extremely careful and actually reporting that they're allergic. When they come into hospital, we see patients re-exposed to chlorhexidine urethral gel, or even in these swabs used for blood testing. So it's extremely important that patients who are chlorhexidine allergic are actually that you take all the precautions and avoid chlorhexidine for those patients. Then a slightly different story. This is a patient who was referred because he had had a cardiac arrest in connection with peripheral nerve block before a shoulder operation, or that was at least the story. When I spoke to the patient, he remembers the preparation for the procedure, and then he felt really ill and was completely gone. And when he woke up, a lot of concerned staff were looking at him, and one of them said to him, "Your heart just stopped for a short while." Basically, I requested the notes for this patient, and what it was, he had a vasovagal reaction in connection with the IV access. He never had any drug injected into him, but they did, and they didn't actually do a peripheral blockade. They gave him a general anesthetic because he had this vasovagal reaction. And he actually also reported being dizzy and lightheaded when he had blood taken, and he'd also been faint during some wound stitching. So this is a person who's prone to vasovagal reactions, and you can tell him that this is what happens, but it is quite likely that it can happen again. So you need to make sure that dentists or other people who have to do surgery or minor things in local anesthetic are aware that this is what happens. So if we're looking at local anesthetics, basically immediate reactions to local anesthetics are much more likely to be non-allergic than allergic. And what you can see is adverse effects from the vasoconstrictor, which is often adrenaline. So you get tachycardia, hypertension, headache, and dizziness, which the patient can get quite worried from if they don't know that this is actually normal, a normal effect of the adrenaline if it goes into a vessel. Anxiety and hyperventilation will show itself as palpitation, lightheadedness, flushing of the face, neck, and chest, which is sometimes confused with a rash, pins and needles in fingers and toes, and a feeling of a lump in the throat. These are all actually symptoms of anxiety and hyperventilation. And then we've got the vasovagal, which we've just talked about. And basically here, again, dizziness, nausea, lightheadedness, clammy feeling, and low pulse and low blood pressure. So, and the anxiety, they've typically got high pulse and high blood pressure, and anaphylaxis is low blood pressure and high pulse. So these don't actually fit the picture. Then we've got toxicity. That's another adverse effect you can have. You can have toxicity from overdose or accidental partial intravenous injection of local anesthetics, which can give metallic taste, confusion, dizziness, this sort of thing. It's relatively rare, but it's also a differential. And local anesthetics are the esters and the amides. And the amides are the ones that have two I's in all names. That's the way you can distinguish them. The amides are the ones we use mostly these days. And if we look at immediate type reactions, actual IgE-mediated allergy to local anesthetics, it's exceedingly rare. And basically, you would have proper allergy symptoms: itching, urticaria, swelling, and then, of course, some cardiovascular symptoms. But there are only case reports. There are no larger studies because it's so exceedingly rare. So actually, when you have allergy symptoms during a local anesthetic procedure, it's much more likely that it's the chlorhexidine, the latex, the excipients, or something else that the patient was, or an antibiotic administered at the same time. Cross-reactivity, again, is much discussed, but it's typically within the same group. So within the esters or within the amides, but not across the groups. And in fact, there's very little literature on it. And you can typically identify a safe alternative on testing. I don't think I've found a case of allergy, a sort of realistic case of allergy to all local anesthetics. Typically, there will be one that you can find that you can use. Non-immediate skin reactions are a little bit in patients where it's suspected, it's about 2 to 4%. And typically it's benzocaine, lidocaine, and kincocaine, and it's typically hemorrhoid creams people react to. But you have to also consider excipients and delayed reactions to those. and you can patch test with the suspected and alternative local anesthetics. And cross-allergy, again, is relatively common within the group, so within the esters, within the amides, but not across the groups. So in Denmark and in Europe, I don't know if you do it in South Africa, but we have got something called the European Baseline Series for patch testing, and that includes cane mix. And sometimes patients will come out with a positive or an irritative reaction on these, even though they've never had an actual reaction to these drugs. And this is quite unfortunate. And unfortunately, people end up getting, diagnosed on a false positive test without a relevant history, and that's obviously problematic because people then think they have to avoid local anesthetics. So when you investigate local anesthetics, the history is incredibly important. Is it a single reaction or there's several reactions? The symptoms, what are they? Were there any skin symptoms? So typically I will ask, were there any skin swelling or itching, any skin rash, itching or swelling? And typically people will say no, because these are so rarely actual allergic reactions. Severity and duration can give you a clue. So people can, with a vasovagal reaction, can feel quite ill for a very short time, but they recover quickly, which is not really the history of anaphylaxis. So the treatment, the response to treatment is of course also relevant. And then of course, if there are actually allergic symptoms, make sure it's not something else that was given at the same time. Tryptase can help you differentiate between IgE-mediated reactions and the non-allergic reactions. And often, actually, patients will have been exposed to local anesthetics. Have they been to the dentist? Have they been to the emergency department? Have they had surgery? And sometimes you can actually find that even though they think they're allergic, they have actually been exposed. And then, of course, you don't have to go any further. Skin testing can be used. If you do it, you have to make sure you don't go up too high in intradermal. So you have to use published non-irritant concentrations. But we usually go straight to provocation in our setting, and we also always do a single-blind placebo-controlled single dose provocation. So we have the placebo and the actual local anesthetic, and what I usually tell people is, we'll give you 2 injections. One of them is local anesthetic, and one is not. It's just saline. But there is so much, people. So many reactions are actually anxiety related or vasovagal that this is a good way of finding out and showing the patients that this is not actually allergic. If there is a suspicion of allergy, we would do a titrated provocation in 2 or 3 doses, and you can also do that in patients with very severe reactions or very anxious patients. Whether you do the provocation with or without the vasoconstrictor depends on the symptoms and what. Sometimes it might be worth giving the vasoconstrictor to show the patient that they might get a little bit of palpitations, so they can get the effect of adrenaline. And also, if you want to test the excipients, typically the excipients are in local anesthetic formulations where there's adrenaline added. But just to show you that in our clinic we did a study of a 5-year period. Of patients coming from dentists and wherever else they came from. And we tested them all with subcutaneous provocation, and all of them were negative. And we did the same with all the perioperative referrals we'd had, a similar number, and all of them were completely negative. So it's very important to take a detailed history and check for subsequent exposure, because often you will actually solve the problem that way. And local anesthetic allergy is extremely rare. Now we move on to yet another story, also a rare occasion, but something that's still overlooked, unfortunately. So this is a patient who came to me with what was termed as idiopathic anaphylaxis. So first she had severe urticaria on both arms when she had a black tattoo on the one arm. And a week later, she had her doctor give her a Depomedrol injection due to hay fever. And it was unusually painful, and within a few minutes, she had intense itching in palms and throat, dizziness, nausea and vomiting, generalized urticaria, and actually she went into hospital and had adrenaline in the ambulance because of the severity of anaphylaxis. And then a week later again, she had reflux, took a chewy tablet for reflux, and again within a few minutes, intense itching in palms and throat, explosive vomiting, generalized urticaria, and went again to hospital. So what could be the common factor here? And basically what it is, it's macrogol or polyethylene glycol. IG-mediated reactions to polyethylene glycol are very rare, but they're more common than local anesthetic allergy. And this is her prick test. You can see she tested positive to this should say Depo-Medrol. This is a spelling mistake. It's Depo-Medrol. She was positive to Depo-Medrol and the chewy tablet, and also to the macrogols in different molecular weights. Now, polyethylene glycol is a polymer of ethylene oxide, in fact. And the nomenclature is a bit confusing because it's either dependent on how many of the ethylene oxide units are joined together. So in cosmetics, for instance, you would talk about PEG 75 if there were 75 ethylene oxide units. But if it was a drug, you typically talk about the molecular weight. And as the molecular weight of one unit of ethylene oxide is 44, then it would be macrogol 74 times 44, so 3,300. So PEG 75 and macrogol 3,300 is the same. So low molecular weights are liquid and high molecular weights are solid. And we've got quite a lot of experience with it in our clinic. And the PEGs are found in so many different things. So patients can react to all sorts of things: laxatives, bowel preps, depot injections, tablets. 30% of tablets in Denmark have polyethylene glycol in it. Gels and sprays, and here are various things that we've seen people react to in our clinic. So various penicillin products and analgesics and that sort of thing. So as I said, it's very rare, but we've got 25 patients in the allergy clinic in Tofte Hospital since 2011, and we've got 3 patients with local anesthetic allergy, so a little bit more common. So when would you suspect allergy to polyethylene glycol? Well, you would suspect it when you have patients who react with very severe allergic reactions to 2 or more structurally different drugs. So a penicillin tablet and a depot injection, for instance. Or people who react only to some doses or some formulations of a drug. So they'll react to a tablet paracetamol, but not the injection. Or people who react to drugs where the active ingredient has been excluded. And then PEG-related drugs, and potentially people with the COVID vaccines that contain PEG, that's probably less likely. But then again, also severe unexplained allergic reactions in connection with surgery and invasive procedures, as many of these gels and sprays and stuff are containing excipients. We only use skin prick test to diagnose these allergies because they're very potent. The PEGs are very potent when you use them on skin prick test. And this is quite a complicated algorithm, which you can read if you're interested. But basically, we don't do intradermals, we just do prick test with increasing molecular weights of PEG. And the higher the molecular weight, the more likely you are to make the diagnosis and the more allergenic. And in fact, just to show you why we don't do anything else than prick test, is because you can actually get systemic reactions just to a prick test with macrogol or PEG. So here's a patient where we used stepwise increase in molecular weight. We did macrogol 300 and 2000, and then the macrogol 3000 was clearly positive, and then the patient started getting wheals all over the body. So obviously we didn't test any higher, but these 3 prick tests with macrogol or polyethylene glycol and related polymers are enough to induce systemic reactions. So skin prick testers only. Lastly, just a little word about vaccines. Now, vaccines are also something that certainly patients can be very worried about. There are all sorts of excipients in vaccines that are adjuvants that help the immune response, such as aluminium salts, preservatives, and stabilizers. Sugars or gelatin are used as stabilizers. Then there are these things that may be in there in trace amount. So basically, a lot of vaccines are grown in chicken embryos or in egg, and the culture media are rinsed away. So in theory, it's a theoretical risk. And the same goes for the inactivating ingredients, formaldehyde, or the antibiotics that are used to prevent contamination by bacteria. They are there in such small amounts that really the risk of a reaction to these, even if you're allergic, is extremely low. One of the things that is discussed a lot is the allergy to egg and influenza vaccine. And actually, this has in large studies been shown not to be a problem for anyone. So basically, the Center for Disease Control and Prevention in the US says now that egg allergy does not indicate additional safety measures for flu vaccination beyond those recommended for any recipient of any vaccine, and regardless of the severity of previous reaction to egg. And in fact, the Quad AI says that guidelines now state it's not even necessary to ask about egg allergy prior to the administration of influenza vaccines, including on screening forms. And in Australia, they're saying the same. Based on prospective and retrospective studies, really, the presence of egg allergy does not increase the risk of allergic reactions to the influenza vaccine. So we certainly in Denmark are also now not going to ask about egg allergy anymore for the influenza vaccine. So what can be another explanation for people reacting to vaccines? Well, symptoms that we see in our clinic is flushing, tingling of the mouth and lips, and basically flushing can be, some people flush when they're worried, when they're, and this is often misinterpreted as allergic symptoms. Tingling of the mouth and lips is hyperventilation. Subjective lump in the throat or difficulty swallowing. If it's the only symptoms, it's rarely allergy. You can never say never, but it's often a sort of anxiety symptom. And then the vasovagal reactions, of course. And this is actually coined immunization stress-related responses. So this can be seen with vaccines, it can be seen with local anesthetics. And this report was really quite good. It came out in 2019, and I didn't discover it before after the COVID vaccine issues. But this has got some very good input on how to manage patients who have these non-allergic symptoms in relation to vaccines or procedures. And basically, the key is to be calm and reassuring and positive and professional. You have to tell the patient that this is not anaphylaxis. If it's vasovagal, you should lie the patient down. It's important to both lie them down with their legs up, but also to stimulate them. Either they stimulate, practice muscle tension, or you sort of rub them on the sternum if they're sort of fading away. It's important to get both the pulse and the blood pressure up. But it's very important that the patient clearly understands that this is benign and self-limiting and not an allergy and not related to the vaccine. And it's very important to avoid an unnecessary medication and hospitalization, or because this will stick with the patient and they'll be really worried next time and probably have another reaction. And this is a little bit of the story with the COVID vaccines that came out. We were all stressed about the COVID pandemic. We got these vaccines and suddenly people were having allergic reactions, and some of us may not have thought that they were really investigated that much. And then also what we found out was that these vaccines contained polyethylene glycol as the first vaccine ever to contain this. And basically some of us were a bit worried of this situation of injecting the patient with this and then 4 weeks later injecting them again, because we were worried that it could potentially sensitize to PEG. This wasn't the way it went, but this was what we were worried about at the time. And in our clinic, this is just to show some of the results that we had. We had so many referrals, as I'm sure you saw in South Africa as well. So many referrals, so many unnecessary referrals. But of the 1,183 referrals we got, 57 did actually have what could be suspected to be anaphylaxis on the story, although the tryptase wasn't elevated, and many of them didn't have any skin symptoms. But what we saw when we revaccinated these patients, we could revaccinate with the COVID-19 messenger RNA vaccine, all 57. And what we saw with the ones that did get symptoms, got flushing, and basically they had at the index reaction flushing, lump in throat, itchy throat, and you could see a lot of them got adrenaline on the first, on the index reaction. But when we gave the second dose, as you can see here, we still got a little bit of flushing, we still got a little bit of lump in throat. We didn't have to give adrenaline to any of the patients. So we could revaccinate all the patients who had anaphylaxis or what thought was anaphylaxis to the COVID-19 vaccine. So we didn't have any anaphylaxis, only milder reactions, most not needing treatment. And we didn't see any patients with an allergy to polyethylene glycol and a reaction to the messenger RNA vaccine. So we published this paper with some good friends to say at the time, please do vaccinate. So in conclusion, on drug allergy investigation, antibiotics are the most common cause. Penicillin allergy can be disproved in 80 to 90% of cases, and it's important to risk stratify and delabel these patients. NSAIDs are the second most common causes, and there are multiple mechanisms, a bit complicated to investigate. And perioperative allergy is rare, but you have to remember the disinfectants, and you have to remember disinfectants if you're investigating patients in a hospital or sort of a healthcare sector situation. Allergy to local anesthetics, exceedingly rare, and allergy to COVID vaccines, exceedingly rare. And in fact, we haven't really found many people, we're not sure of the mechanism, but the reactions are typically mild and they can be revaccinated, which is important for future vaccination. That was all I had. Thank you very much for your attention, and I'm now ready to answer any questions.